Hello guys, welcome to my channel, Pajon Imaging Hub. In today, radiographers and other health professionals series, we'll look at pleural effusion. We'll look at important things we often do not know it counts. Please don't forget to like, share and subscribe to my channel so that you'll be notified when new video is released. Thank you. Welcome back. So what is pleural effusion? Pleural effusion is simply the accumulation of fluid in the pleural cavity. What is pleural cavity? Pleural cavity is the space between the layers of the pleura. The pleura contains of two layers, the parietal and the visceral layer. The visceral layer is continuous with the lungs, is attached to the lungs. It's difficult to separate the two. Then after that, there is a space before you now have the parietal layer of pleura. So that space, accumulation of fluid there, is pleural effusion. So what causes pleural effusion? How did the fluid get in there? Pleural effusion is caused by two major things: the transudate and the exudate. These are fluid. So what is transudate? Transudate is the fluid that comes out of the blood vessel due to imbalance in hydrostatic and oncotic pressures. If you watched my video on pulmonary edema, you will see how I took time to explain these hydrostatic and oncotic pressures and how they work to cause effusion, or how they work together to keep fluid in the vessels, and how imbalance of the two can cause fluid to come out of the vessel into the external spaces. So this transudate is a thin watery fluid with low protein content, typically caused by imbalance in hydrostatic and oncotic pressure within the capillaries, that is the blood vessels, leading to fluid being forced out of the vessels. Now, what is exudate? Exudate on its own is a result of inflammation or injury to blood vessels, causing them to become leaky and allowing fluid, protein, and cells to leak out. Now, one is caused by damage or injury or inflammation, while one is due to imbalance between hydrostatic and oncotic pressure. Now, in X-ray cannot show the difference between these two fluids. We cannot see the difference in X-ray. But knowing the type of fluid is important in the management of the patient. Transudate is a filtration of blood due to pressure changes, while exudate is a leakage of fluid from damaged or inflamed blood vessels. Then transudate are primarily composed of fluid, while exudate contain fluid, proteins, and cells. So you see, it's easier when you get the fluid, the aspirated fluid, when you're aspirating the effusion, pleural effusion. It's easier to identify which one is which when you do biochemical analysis. The presence of high protein and cell counts in exudate is a key indicator of inflammation. So you can use it to make an inference on what could be causing the pleural effusion. White transudate are typically associated with systemic conditions affecting fluid imbalance. So you can see it's very simple. Let's look at radiographic appearance of pleural effusion. Having known the causes and the difference between transudate and exudate fluid, there are about 5 basic radiographic appearance of pleural effusion in radiograph. We have the first one is homogeneous dense opacity. The opacity you're going to see is going to be homogeneous. It's not going to be mixture of air and the fluid like we see in the pneumonia and other things. Then there is no air bronchogram. like we see in pneumonia. There is loss of costophonic angles. The angles where that is affected by the pleural effusion, you'll not be able to visualize it. It will become blunt. It won't be acute. That is supposed to be. Then there is a loss of hemidiaphragms. The affected diaphragm, you will not be able to visualize the border. A meniscus sign. So let's look at the radiographic features of the pleural effusion. We'll look at this other image, the costophonic angle. You can see it is not acute, it's blunt. See, it's blunt compared to this one that is not affected. This appears to, you see the two, the first one and the second one. This is just simply showing you that the posterior aspect of the lungs and the anterior aspect of the lungs. So, but the two are pleural effusion. You see, it has a homogeneous density. It has a concave upward, tracking towards the border up concave. Then there is no air bronchogram. You can't see any air bronchogram. Then you cannot visualize the hemidiaphragm of the affected site. Then the costophonic angle also is lost, unlike this one that is acute and normal. In this case, we'll see the homogeneous opacity. Then we cannot visualize the costophonic angle. The diaphragm is not clear. Then the diaphragm we cannot is not clear. Then the meniscus sign. We cannot appreciate the meniscus sign because we talk about the hemidiaphragm not being visible. This hemidiaphragm is visible. Here we cannot really know where it is. It is obscured. Then the meniscus sign. You see that this edge is striking up. This one is striking up, so it will now become concave upward. That is meniscus sign. It has a lesser. This fluid has a lesser cohesion. So you see, it is tracking up. Tracking up is one of the key feature of pleural effusion. We'll say it has a homogeneous opacity. So this is pleural effusion. So you see this place is homogeneous. We can't see any air bronchogram or any heterogeneous density there. They just appear white. Then we'll say, of course, there is no air bronchogram. Then the costophonic angle here, we cannot appreciate it here. We can't appreciate it. We can appreciate this one that is not affected, but here we cannot appreciate it. The whole lungs is covered by this fluid, so we can't see the edge up. So we cannot really appreciate the meniscus, and the whole place is covered with fluid. So there is no air bronchogram you can see. We look at this other image. We see this is a homogeneous opacity here. No air bronchogram. We cannot visualize the costophonic angle and the hemidiaphragm, and the other hemidiaphragm cannot visualize, and the costophonic angle is not visible. Then we see the meniscus sign. You see this? See this? It goes this way, this one goes this way, so you can still appreciate it. It's still concave upward. Then we'll see this other one. This is very massive pleural effusion. You see, when pleural effusion become massive, it can push the mediastinal structures to the opposite side. This pleural effusion. So you see how it's pushed the trachea, the bronchioles to the other side. Even the heart, you can see the heart border is pushed it to the other side. It's massive. There is no air bronchogram you can see. You cannot visualize the costophonic angle. You cannot visualize the costophonic angle here or the hemidiaphragm, but you can appreciate this one and the costophonic angle. Now, having known the different features of pleural effusion and how to detect them in the radiograph. Let's look at the difference between pleural effusion and collapse, because most cases this used to be a problem and can cause the misdiagnosis can be very costly. One principal difference between collapse and pleural effusion is that in all virtually all collapse, there is always shift of mediastinal structure, no matter how small it is, to the side of the collapse. But in a fusion, it is only when it is massive that there is a shift in mediastinal structure, but to the opposite side, not to the side of the pleural effusion. So this is a major difference. So look at this image. This one is collapse. Is right lower lobe collapse is always triangular. If you watched my video on lung collapse, you appreciate this image. Then you see there is a mild shift in the trachea. There is a shift in the trachea towards the side of the collapse. Now this image is homogeneous. You can't appreciate any air bronchogram. So what helps us to differentiate it from pleural effusion is this shift in the trachea to the side of the collapse. Then if you look for other signs, you see that there is there is no meniscus sign. This one is convex upward. Then this other image here, you can see the meniscus sign is concave upward. Then you see we cannot appreciate the costophonic angle. Then this trachea is at the midline, but even here that it appeared to be deviated, it is to the opposite side, not to this side of the pleural effusion. So this helps you to differentiate between collapse and pleural effusion. Thank you. Like, share, and subscribe to this channel. Bye for now.